I'm back. Okay, so team, it's just gone 6:30, and I think we'll start the webinar now. First up, many thanks for all of you who've taken the time to join us today. I'm joined today by my colleague, Dr. Fahar Khan, as well as Rosie Flynn, who's our in-house nutritionist at One Heart Clinic. And we're shortly to be joined by another one of our colleagues, Dr. Rebecca Schofield. So my intention is just to get the ball rolling by sharing my screen and my slides. So let us start the slideshow. So we are One Heart Clinic. This is our second patient forum. The last time we did this, I think we were very pleasantly surprised by the level of engagement, and we'd still value that we continue with that. So on the Zoom platform, there is a Q&A box, and we'd encourage you to use that liberally. Fahar very admirably types away, answers your questions, brings interesting kind of remarks or queries or questions to the whole forum. And this is very informal. It's a panel discussion. We'd like for this to be a two-way discussion. We hope to learn from you as hopefully you'll learn from us. There's no right or wrong answer. And the topic we're discussing today really is got a lot of kind of variety of opinions, controversies, and uncertainties, but a very important area that's been growing and certainly a bigger part of our practice. Um, I'd like to talk about obesity in the UK and the role of nutrition, exercise, and the hallowed weight loss injections, which seem to be gaining increasing popularity. So today in the United Kingdom, 28% of adults are obese. And by that, I mean their BMI is above 30. And a BMI, for those of you who aren't aware, is your weight in kilograms over your height in meters squared. A BMI below 25 is considered to be normal weight. Between 25 and 30 is considered to be overweight. And anyone over 30 is considered to be obese. 30%, 36% of the adult population are overweight. So actually, nearly two-thirds of the UK adult population are either overweight or obese. More worryingly, our future generation, the problem may be even worse. Approximately 20% of children aged 10 to 11 are living with obesity in the UK. To put this in perspective, 20 years ago, the adult obesity rate in the UK was only 15%. Now, on the picture on the left, I've shown you, you've got a picture here of really what I would hope is not something that all of you are consuming at home. But I'm afraid to say that in every single NHS hospital I worked at during my career, all of the items on that picture, the French fries, the sugary drinks, the donuts, were available in abundance and easily accessible. Whereas kind of more nutritional foods were hard to come by. And that was for patients visiting, for people visiting patients, for patients themselves, and for doctors on call overnight. So really, nutrition is something that I think, unfortunately, in the healthcare system, we really need to catch up on. I recall, Fahar, do you remember how many hours of nutrition lectures that we get in nutrition? Fahar and I were at the same medical school. My recollection is we only got an hour or so, and even that it was very much get the handout and no assessment thereafter. Was that your recollection?
Yeah, and I think I skipped that one actually. And as we discover later on in the webinar, you're right. There was not enough emphasis um, on these lifestyle changes. Absolutely, and it is now the bedrock of how we manage many of our patients. So I think I absolutely agree. More emphasis needs to be put on that. And I think today will be really great opportunity to share some of our thoughts and some of our strategies and some personal experiences as well.
Brilliant. Okay. So, I mean, why is obesity such a big deal? Well, it's a very start. There's a lot of it around, and it is a big deal because due to the process of inflammation, insulin resistance, it can cause a lot of harm. And here are the main kind of conditions that obesity is linked to. You'd have all hopefully realized that obesity and type 2 diabetes go hand in hand. The more overweight you are, the higher the risk of diabetes. And one of the best ways of reversing new onset diabetes is weight loss. It's also linked with coronary artery disease, strokes, but things like arthritis, cancer is also linked to obesity, as well as liver disease, acid reflux, and sleep apnea. Now, the good news is that just by a modest amount of weight loss, 5 to 10% weight loss, and this is scientifically proven, you can drastically reduce your risk of type 2 diabetes, cardiovascular death. You can improve your lipid profile, and by that I mean your cholesterol can reduce. You can reduce your blood pressure, and certainly that's how I managed to control my blood pressure when it was a bit borderline. Those of you who've had sleep apnea, weight loss is always the first line to get that better. And generally, there are mental health benefits and an overall improved quality of life. And this isn't me just saying it, this is very much proven in various scientific journals. So really the trick about weight loss is first of all to recognize that it's something that needs to be done. I recall the times when I've put on weight, it's without really knowing it. And that typically happens when I don't weigh myself regularly. And on a couple of occasions, it was my mother and my wife who said, I think you need to lose some weight. And I think if your wife and your mum are telling you you've put on weight, there's really a problem. So what I've always struggled with is kind of how do you do that in terms of nutrition? Can put my hand up and said I have tried every single diet, keto, paleo, low carb, no carb, low fat, no fat. And through lots of messing around, it's pretty clear to me that actually common sense, balanced diet is the way forward. So at this point, I'm going to invite Rosie, who's our nutritionist, and just kind of pose the question. Rosie, we send you our patients. If a patient comes to you and says, look, I need to lose 5 or 10 kilograms, what would your advice be? And I've put on this slide, these are my personal thoughts, and I'm panelists Rebecca, who I can see has joined, Rosie, Fahar. If you disagree with anything I've put on here, please do say. But I think my understanding is 70% of your weight loss is due to efforts with diet. You can't exercise your way out of being overweight. You can exercise certainly as a catalyst. But what's your typical advice, Rosie, in terms of the nutritional plan for someone who wants to lose 5 to 10 kilos?
So we would have to look at what their existing diet would look like and how that could be improved. So for example, we have to look at things like their protein intake, fiber intake, what their unsaturated fat intake is looking like, and how much are they going over the recommended calorie allowance as well. So I think the best way is to not be too overwhelmed by all the things that you can change and start with one change at a time. So it might be, for example, drinking more water, which does have a good impact on our digestion. Or it might be just reducing things like sugary drinks if that's something that someone has an excess of in their weekly diets. There are small changes that you can make that will have sustainable effects rather than kind of crash dieting and saying I'm going to limit my calories to 500 a day because it's not sustainable. So it's about making small incremental changes and then measuring the progress down the line. So that could be looking at things like weight or energy levels and how you're generally feeling.
In terms of kind of people's lifestyles, very busy. I certainly find it very hard to prepare my meals. Is this kind of shop bought stuff that you can get from the chilled food counters or frozen counters, is that good enough, or should we really be focusing on freshly prepared food? Is that something that you find that a lot of people have challenges with actually taking the time to make the appropriate meals for themselves?
Yes, it is difficult because I think with marketing and what we have available, it's a lot easier to grab something. I think it's quite important now to start being aware of looking at food labels. So look at the things like added sugars, added sodium, and the general calorie content. So a lot of food labeling now has the traffic light system, the reds, the greens, and what's high in fat, what's high in sugar. Those are good indications of what to avoid or what to have more of. And it is difficult when you don't have time to prepare things like breakfast or lunch. It is more ideal to be able to cook at home because you know what's going into the food. But you do have to be aware of portion control as well, especially if you are cooking not just for yourself.
Right. Rebecca, maybe I can bring you in on this point. You're obviously someone who one of the few cardiologists who actually has kind of done a lifestyle prescribing course. So I think we've got a lot to learn from you. Question for you. I mean, we talk about counting calories. Is that a good idea or a bad idea?
I think probably the most helpful thing, Ravi, would be to start with an honest food diary. I think that a lot of us aren't aware of exactly what we consume on a day-to-day basis, that we are subject to a degree of sort of retrospective blindness as to what we've actually eaten. So I think keeping a contemporaneous, honest food diary to start with is quite helpful, because then I think you can highlight areas of where you can easily remove additional calories. And as you've already said, you can't exercise out a bad diet. So to think that, if you're doing lots of exercise, that's all you need to do is not necessarily true. And then I think the other thing that certainly that's talked about a lot in terms of prescribing lifestyle medicine is not just about nutrition, but it's about the other three pillars of, or other pillars, depending on which school you subscribe to. But the impact that all of those other things have on our nutrition, so our quality of sleep, our stress levels. So looking at then triggers for why you overconsume or when you consume, and how that's influenced by other aspects of your lifestyle. I think that's quite helpful.
Yeah, no. So I mean, my view about calories is it's a necessary evil. So I mean, you shouldn't. They do count, and it's something that to get things going, you can track. I think for me, the real thing that I focus on is protein intake. The kind of official guidelines are to have 0.8 grams per kilogram, which, from my understanding, that's not nearly enough. And the key thing about adequate protein is your building block in terms of maintaining muscle mass. So if you're losing weight, what you don't want to be doing is losing muscle mass. That is unsatisfactory. You want to be burning fat. So the way of doing that is to increase your protein intake to about 1.6 grams per kilogram body weight. And for me, it's clear. I think the days where I used to say zero carbs, that's nuts. I think you have to have carbohydrates. Carbohydrates are fuel. We've got to have good quality carbohydrates and tend to aim for whole grain carbohydrates. Sugar for me has no nutritional value. It's a treat. It's a white powder, so I consider it a drug. And alcohol, I certainly enjoy my red wine, but I think less than 10 units a week is probably what I would suggest. Would you all agree with that, Rosie, Far, Rebecca? Great.
Yeah.
Okay. So how do we know how many calories we need?
Can I just raise a point to do with what Rosie had mentioned about water?
Yeah.
And now that's a key thing. In fact, we've got a question here about when you lose weight initially, the initial weight loss may just be fluids and water. And therefore, and the question has been asked: what impact would that have on blood pressure, particularly when somebody's got hypertension, in terms of managing their fluid requirements under these circumstances? So, so the question is really related to your fluid status, high blood pressure. What should we do about fluid and salts under these circumstances?
Yeah, so I mean, for me, I mean, I think we can all opine 2 liters of water a day is my kind of minimum. With blood, generally, if you lose weight, your blood pressure should come down. So for every kilogram of body weight you lose, as a rule, 1 millimeter of mercury reduction in your blood pressure. So I think weight loss is good for that. In terms of salt, obviously, kind of stick to the dietary guidelines. I wouldn't increase, but it'd be interesting to see what others have to say about that. Rebecca, perhaps, maybe, or Rosie.
No, I'm in agreement with that.
So I think two liters a day is what we'd advise. So we've talked about kind of being in a calorie deficit, and just to kind of reiterate, if you want to lose a pound a week, you have to consume 500 less calories than you are burning. So how do you actually know what your calorie requirements are? So there's lots of these calculators available on the web. They all roughly give you the same idea. I've tried a few, but a nice simple one is this one, where you put in your age, your gender, your height, and your weight. And that gives you something called your basal metabolic rate, which is basically the number of calories you need to lie in bed all day, just breathing, not eating, not doing anything. Now, what happens is you then need to factor in how much exercise. And this is what I mean by exercise. Exercise is almost like a kind of a turbocharge for your metabolism. And if you do little or no exercise, you kind of have a certain allocation. But the more exercise you do, the greater the kind of requirements are, because the greater the fuel needs are. And providing, so for example, I exercise, I'd say probably around 3 to 4 times a week, between that, maybe 5 times a week. So my calorie requirement, this isn't my metric, but if it was, I would be aiming for a calorie deficit of 500 calories, which meant that I'm probably consuming 2,300 calories. As Rosie has already kind of hinted to you or said to you, kind of going for that extreme restriction of saying, no, I'm only going to have 800 calories a day is a recipe for disaster. All that lands up happening is you have a horrific rebound hunger a few days later because it's not sustainable. You overdo it and completely mess up your calorie deficit. And the other thing that happens is your body sensing starvation then basically just slows down the metabolism and starts to burn less calories. So it's a vicious cycle. You ought to just aim for no more than really a 500 calorie deficit for a week. So that's kind of how you know what your calorie requirements are and how to kind of go for a calorie deficit of 500 calories. So we've kind of spoken about nutrition, an overview. Exercise, it's got huge physical and mental health benefits. In terms of protection against dementia, exercise is by far the most potent protection you can have against dementia, which is the biggest killer in the United Kingdom. And exercise should be balanced. I think I'm 50 now. In my 30s, when I was kind of coming to the end of my training, I had just kind of had a young family. I basically didn't do any exercise for 2 or 3 years, so I was 10 kilograms heavier than I am today. But also my stress levels, my ability to kind of process stress and cope with kind of work-life balance was far less. And I started running, which was tremendously helpful. But as you get older, you need to do more than that. Days of just plodding on a treadmill or kind of cycling isn't enough. You need to also supplement the core cardiovascular aerobic exercise with resistance training, which basically means lifting weights or body weight exercises. Because really, after the age of 40, what happens is you're starting to lose muscle mass. And the best way of maintaining and, in fact, increasing muscle mass is resistance training. So for certainly anyone above the age of 40, if you are exercising, great. But if you're not doing resistance training, it's time to do that. And that doesn't mean you have to join a gym, because I know a lot of people don't enjoy that. That means you just need to be doing things like push-ups. You can have dumbbells at home, resistance bands. And the third kind of exercise is isometric contraction, which is things like yoga, Pilates. This stuff I really hate because I'm rubbish at it. I'm very inflexible. But those are the main kind of exercises that you should be incorporating. And for things like blood pressure, every single one of those types of exercises independently reduces your blood pressure by 2 or 3 millimeters of mercury. So if all you did was cardio and nothing else, then very simply you'd be missing out on benefits from resistance and isometric contraction. So Rebecca, when you prescribe exercise, how much and what's the kind of formula that you suggest?
So I think the first thing is to work out what the patient's lifestyle looks like and what's achievable in terms of a commitment to exercise. Because I think often if people start with too big a goal, too big a jump from nothing to extreme, you can't achieve that, or if you can achieve it, you can't sustain it. And then through that becomes sort of negative thoughts about oneself and feeling of failing and therefore not incentivized to continue. So the first thing I think is to work out realistically how much time have you got to commit. And then also thinking about the patient, the patient in front of you and what access they've got to a gym financially, what resources they have available to them. So not again to prescribe or suggest things which are unattainable. And there's a lot that can be done in one's own home, and there's a lot of exercise that can be done within a community. There's lots of social prescribing and ability to have a reduced membership to local gym facilities, etc. So working out what's available in that patient's area and signposting and directing them. And then, as I say, keeping the goals initially achievable and building up then to at least 30 minutes of exercise 5 times a week that makes them breathless to the point they can't hold a conversation. I mean, sometimes we have the other extreme where you're sort of trying to pedal back a little bit because somebody's got quite a large sort of profile of exercise, and actually that also can be detrimental. So that's my approach.
But Rebecca, when I ask the question, what exercise do you do, which I now routinely ask in my consultations, people say I walk 8,000 steps a day or 10,000 steps a day. Would you count that as exercise, or would you classify that as movement?
I personally, I mean, I don't, the term of sort of exercise and movement, I think in some ways are interchangeable. And some people find the term exercise daunting. But yes, I think if someone was to say to me, well, I do 8,000 steps a day, I would say that's normal physical activity. I'm talking about something above and beyond that.
Yeah, that's my view as well. So, I mean, I'll tell you, it's from the age of 35, doing no exercise. For me now, exercise is literally like something that it's like if I don't exercise, it's like not brushing your teeth. I just can't imagine without it. But it's, as you said, it's taken kind of 10 years to kind of get into that my way of thinking. And you know, I do 120 minutes of cardio. I do some resistance training and a HIIT session, and Pilates, which I'm absolutely awful at, which I acknowledge is very good for me. And I aim to do 10,000 steps a day. I have to say, you know, I aim for 70,000 a week because there are some days where I've done 3,000 and there are some days where I'll make up. So on average, I kind of aim to do 70,000 steps a week. But we talk about weight. Now, if I go to the gym and did the BMI for every personal trainer there, they're either all overweight and some are obese, but clearly they're very physically fit. So I think what in my own practice we're looking now to do is talk about body composition, because a kilogram of fat and a kilogram of muscle weigh the same, but a kilogram of fat is a lot more voluminous. So you'll have people who are lean, who've got very little fat, but actually weigh quite a lot because muscle is much denser. So you know, you can lose weight, but you need to lose the right kind of weight. You need to lose fat, and you need to preserve muscle. And the ideal is to actually put on muscle and lose fat, as we've seen in this graph. And what we don't show you is the weight, because actually the weight hasn't changed that much, but the body composition is much better. And I'm glad to say now that a lot of the weighing scales that you get actually have body composition built in naturally, although I have to say the quality and the reproducibility are somewhat kind of variable. This particular device that a lot of doctor surgeries are now getting, and also available in certain gyms in body, is actually incredibly useful. And I wouldn't obsess and do this daily. This is the kind of thing I may do every 6 weeks or so to keep track of things. But it is key to say that actually, if you want to lose body fat, then your actual kind of total body weight is a pretty good surrogate. But by using something like this, you're also ensuring that you're not just burning muscle off. I mean, the gold standard is this, which is called a DEXA scan, where you lie on a table, and it's a kind of an X-ray machine, very low dose X-ray, the equivalent of eating 11 bananas, I'm told, or 1 day's background radiation in the UK. Where after 4 or 5 minutes of scanning, you get a very detailed picture, as seen on the right, about your body composition. And this tells you about kind of how much fat you have, your fat percentage, your muscle percentage, as well as critically something called visceral fat. Now, visceral fat is something that even us as kind of doctors and cardiologists specifically have only really become aware of in the last kind of few years. You have fat, subcutaneous fat under your skin, which is actually a good source of energy store and insulation. But then what happens is when those kind of areas to store fat are exhausted, fat starts depositing around the organs, and that's called visceral fat. And that's dangerous active fat that is has the potential to cause inflammation, insulin resistance. And a DEXA scan will actually tell you what your visceral fat percentage is. So you may have good levels of visceral fat and slightly higher subcutaneous fat, but it's a visceral fat that for me is the marker of real risk. Generally, though, if you lose body subcutaneous fat, your visceral fat tends to kind of go in the same direction. Anyone else have any kind of more thoughts on weight, body composition before we move on to the, I think probably what a lot of people have tuned in to hear more about? So Rebecca, do you track body composition, or is it kind of weight in your patients who
I'm not sure I'm necessarily prescriptive on either. I mean, I think the point that you make about fat, a 1 kilogram of fat and 1 kilogram of protein weighing the same, as obvious as that is, they're metabolically poles apart. And as you've already said, that this concept of visceral fat leads to significant changes in how we handle cholesterol, inflammation, etc. So I think being cognizant and an understanding of body composition is important. As you know, I do a lot of imaging, and so I will sometimes spend time going through CT scans, for example, or MRI scans, just to demonstrate just what's happening. Because in certain cases of extreme visceral fat, particularly around the heart, you can start to see the hemodynamic consequences sometimes of this significant amount of pericardial fat and how that is affecting cardiac function. So I think sometimes it's helpful to see things to promote a change in behavior. Yeah.
So about whatever 25, 30 years ago, I had all these various uncles coming out of the woodwork asking me if I was a doctor. And then asking me if they could prescribe a medication for them, and that medication was Viagra. And in more recent times, I've had lots of family members, friends, but this time it's not kind of elderly Asian uncles, it's a variety of people asking about whether I could prescribe weight loss injections for them. And certainly these are probably some of the most widely prescribed medications in our practice. Certainly I'm prescribing them week in, week out, because they're excellent medications for diabetes, and also they reduce the risk of heart attacks and strokes. But those indications have largely been superseded rather by the key indication of weight loss, because these are considered miracle weight loss drugs. And indeed, they are excellent. I'd like to kind of maybe spend the next 15 minutes or so before we switch to Q&As, talking about how we came to be here, how these medications came to be, what the risks are, what the benefits are. So I don't know about you, but I always like to think about the origin story. How did all of this start? How did Bruce Wayne become Batman? James Bond is now with Amazon. I'd love to hear kind of the origin story of how he became who he was. And really all harks back to a diabetes drug called the glitazones, and rosiglitazone is an example. And these were great drugs at reducing your blood sugar. But the unfortunate and unforeseen consequence was that although they reduce your blood sugar, they increase your risk of heart attacks, heart failure, and also osteoporotic fractures. So on that basis, the authorities both in the UK, in the US, the FDA, and in Europe, the MHRA, mandated that any new diabetes drug that was released had to have something called a cardiovascular outcome trial, which meant that these drugs needed to be trialed in patients in a controlled manner to prove that they did not cause cardiovascular harm. They did not cause heart attacks or strokes. They didn't need to show they were beneficial. They just needed to prove that, sure, they reduced blood sugar, but not with the unforeseen consequence of actually causing heart attacks and strokes. So what happened was these GLP-1 analogs, one of the first group of drugs to have to undergo these cardiovascular outcome trials. And just to say what GLP-1 is, a naturally occurring hormone in the gut that basically makes you feel full. It stops you feeling hungry, and it does that by increasing the amount of insulin and slowing down the amount of gastric emptying. So it makes you feel full. And one of the first trials was with semaglutide, which is also known as Ozempic or Wegovy. And they looked at patients who had diabetes, and this was a trial to prove that it was safe. And what they found was not only was it safe, this is something called a Kaplan-Meier curve, which us as doctors are used to seeing, but I'll talk you through it. What they do is they take two groups of patients, they give half of them Ozempic, half of them get a injection with basically just water in it. And they then follow these patients up for weeks, and you can see this kind of heads out into a couple of years. And they see how many of these patients have heart attacks, strokes, or die from cardiac causes over that period. And you will see here that the people who were on semaglutide actually had a lower risk of heart attack, stroke, or death compared to those who were given the placebo injection. So this actually tells us not only is this drug safe, it does not cause heart attacks and strokes, but actually it protects against heart attacks and strokes, which is why it is one of the most favored medications for diabetes, because not only does it reduce the blood sugar, but it also protects against your patient having a heart attack or stroke. And it's about a kind of 26% reduction, so almost reduces the risk by a quarter. Now, an unforeseen consequence was that actually in these patients in the trials, what they noticed was that not only does it reduce blood sugar, not only does it reduce the risk of heart attack or a stroke, but it actually also causes weight loss of about 4 kilograms, which is fantastic. And that led the researchers and the drug manufacturers to ask the question, can we use this not just in diabetic patients, but also in non-diabetic patients who are overweight or obese, and see whether it reduces weight effectively. And you will now know that actually those trials were wildly successful. And critically, just like those patients who had diabetes, even if you didn't have diabetes, these injections reduce your risk of heart attacks or strokes by about 20%. So it seems too good to be true. You've got something that reduces your blood sugar, makes you lose weight, but also prevents you from having a heart attack or stroke. So the question is, why aren't we all having them? Well, one of the key issues is cost. Access to these drugs is very limited because they're expensive. But another key issue is that we don't want people simply to inject themselves out of weight loss, because you can't keep injecting yourself forever. It's really the core of nutrition, exercise, and we've discussed. There are also some clear warnings that we need to give our patients, and this is a list of everything I say. This is a list of everything I say to my patients. I've got it all written down in a sheet that they get. In rodent studies, in the animal studies for these drugs, it actually causes a form of thyroid cancer. So if there is a family history of thyroid cancer or something called multiple endocrine neoplasia, we recommend you don't take these medications. Very rarely, it can cause acute inflammation of the pancreas, a condition called pancreatitis, which will actually result in, which has the potential to cause death, if not severe pain and hospitalization. If you have pre-existing diabetes, it can make your diabetic eye disease worse. And very rarely, if you've got a concomitant gastroenteritis, it can cause acute kidney failure. More recently, there's been also concern about a rare eye condition called non-arteritic anterior ischemic optic neuropathy. And the real concern here is it can cause sudden visual loss. And the more we use these drugs, the more I think we find that these are not entirely without risk. Finally, the side effects that we always warn our patients about are the gastrointestinal side effects: nausea, vomiting, diarrhea, abdominal pain. And that's why we start off at low doses, typically tiny doses, which we give for a month. And if the patient tolerates that, we increase the dose by a certain amount, and it depends on which drug you're taking, until they're on a dose that they tolerate and they're achieving weight loss. Now, how much weight can you lose with these drugs? With Ozempic and Wegovy, typically around 10%. With Mounjaro, which is the newer drug that has two analogs, two ways of mimicking hormone-related satiety, you can probably get around 20%, which is not far off the old-fashioned bariatric surgery. So I'd now like to move on to case study. I think this is very brave of Fahar. That photograph was taken in 2018. All of us were having our photographs taken. Fahar got it the first time. Every time we had a photo, he looked great. My colleague Shai and I, it took about an hour and a half before we managed to smile without looking into the faces. So Fahar, why don't you tell us about your kind of journey with weight, nutrition, exercise?
Yeah, thank you, Ravi. And I think it's a good opportunity just to bring a personal experience, just because we see a lot of these patients, we have these conversations in our clinic room, and actually it's important to understand that we recognize that there are many, many challenges on that journey. So over the last few years, I've been my weight has fluctuated quite significantly, and actually Ravi's got a graph, and this is a graph which shows what's been happening with my weight now. You'll see that my weight went up massively. If you look from the left-hand side of this screen, my weight went up quite to a significant amount. And I really had quite a significant impact upon me. A lot of things going on, usual story, busy life, multiple things going on in personal life, multiple things going on in work life, and complete disregard for your own health and fitness. So at this point, where you see that peak, which is just being shown on the cursor at the moment, you see I had a consultation with a cardiologist, and I think this highlights some of the things that Ravi's been talking about at the moment. These drugs, although they are readily available and you can get them online, you really have to take some professional advice with regards to how you manage these drugs. Have bloods before, make sure there are no other issues, talk to somebody who is an expert, be counseled on the potential side effects and potential risks with these drugs. So I did that, and I had an interaction with a cardiologist. And I went on Ozempic and increased my dose, got to quite a decent dose of Ozempic, and lost quite a significant amount of weight. This is around about 10 or 12 kilos of weight. But what I didn't do at that time is I didn't make any significant lifestyle changes. Once again, I was still working 100 miles an hour, not really focusing on the lifestyle aspects. And as a result of that, when I stopped the Ozempic, only because I thought I was making such good progress that actually I don't need the drug anymore, what actually happened, I had a massive rebound in my weight. And I realized that the Ozempic was actually doing the work, and I hadn't actually made any effort or hadn't actually put in any of my own blood, sweat, and tears to really influence this lifestyle journey. And there you can see the weight came back straight away. Essentially, your the appetite that is switched off by the Ozempic, essentially the brakes came off, and you're back to eating, and then essentially the weight piles back on. So then what I did at this point was there's a plateau. Once again, really spent a little bit of time looking at what I really need to do. And at this point, I made quite a significant number of lifestyle changes. And I would say that I would summarize those in 5 areas, much of which has already been discussed in this webinar, but I'm going to just summarize it. I took on the aspect of changing my diet and moved to a high protein diet, low carbohydrate diet. That was the first thing I did. Second thing I did is I worked out my basal metabolic rate and calculated that what my calorie intake was, took 500 off that, and then set that as my target for the 24-hour period. And actually, that still worked out that I could eat up to 1,800 calories a day and still be a 500 calorie deficit. So it was quite a generous provision of calories during the day, something which was sustainable. And I set myself the idea that I will make that'll stick within the 1,800 calories as an average over a 7-day period. So there would have been some days where you allow yourself to lapse. But the average over that 7-day period would be a 500 daily deficit. The third thing that I did was I did 15 minutes of resistance 4 or 5 times a week. And that was very simple things that I did in my own home. Lunges, press-ups, squats. Didn't have any equipment to start with at all. Just simple bodyweight exercises that anybody can do, but I've had the discipline to do that 4 or 5 times a week. And I actually do quite well with intermittent fasting. So I switched to a window of nutrition of around 6, maybe up to 8 hours, but mainly a 6-hour window where I would consume the 1,800 calories. And on the basis of these changes, resistance training, high protein, intermittent fasting, and eating to 500 calories deficit per day. And I also added an average of 10,000 steps for a 7-day period. So during those busy days when I'm at work, I can't get them in. On the weekends, I'd make sure I'd get a long walks in. And the key with the walking, which has come up quite a lot in the questions which I've been fielding, is that you've got to get into the zone 2. So you've got to get to 60 to 70% of your heart rate. So what that means is you calculate your maximum heart rate as 220 minus your age, and then you exercise to a level which is 60 to 70% of that. And the easiest indicator of that is that if you're walking, you'll be a little bit breathless, but if you are with somebody or on the phone, you could hold a conversation, but they would know that you're doing some form of physical activity. And that needs to be sustained, and you need to do 150 minutes of that over a 7-day period. So incorporated all of those changes. And as a result of that, now you're seeing much more steady weight loss and much more sustainable weight loss.
And are you taking Manjaro Ozempic to help with this?
No, no.
So this is all without. So the first
Yes.
time you got a result and then it all rebounded.
Because it's not a long term. So now you'll see that there may be a bit of a plateau coming on. Now I feel comfortable about going on Manjaro because I know that I've made, so if I need a bit of a boost for a few months to get the Manjaro to get me to my target, but I know that the key thing is I've made the changes. And the key mantra for me is to make a very small change, but over a very long period of time.
Yep.
So that for me is the lesson, that is the lesson that I've learned. And actually the shortcuts with these drugs don't really work unless you're taking them for a sustained period of time. What you really need to do is you use the drugs while you make the lifestyle changes and to help you lose weight during that period of time. But eventually that crutch will come off. And what you really need to rely on is that lifestyle change. And we had some questions that I fielded related to what do you do when you fall off the wagon? I think the key way of getting back onto the wagon is to accept that you're not going to get back onto the wagon straight away. You just need to make that small change once again and sustain it over a long period of time. And that is the key. It's a long-term plan here. There's no short-term fix here. No crash dieting, no crash calories. This is a small change over a long period of time. And that's the most effective way.
I mean, I think we all have to accept 2 steps forward and 1 step back is still net 1 step forward. You know, we all have that. Rosie, Fahad talks about intermittent fasting. And I've heard mixed, whoever I speak to has slightly mixed views on it. What are your thoughts about intermittent fasting?
Yeah, there are mixed views on it because there is still quite a lack of research on humans. There are a lot of animal studies done on the benefits of it. I think when people are reducing their calorie intake, what we mentioned as well beforehand is that also losing muscle mass is going to be affected, and that is detrimental to managing weight and health in general. I think it can be quite an individual or personal preference, really. Some people don't have an appetite in the morning and they find intermittent fasting just works for their lifestyle. They might be too busy to eat. At the same time, we don't want to skip meals if you know that if you skip breakfast, you're going to double up when you have lunch. So it's very much more of an individual preference at this point. I couldn't say that it's going to be all around beneficial for everyone.
So certainly the scientific studies haven't really shown a benefit. I think for me, the biggest benefit potentially is if you are trying to be in a calorie deficit is that you basically reduce your kind of opportunities to have calories, providing you restrict, you still stick with lunch and dinner and keep an eye. Then it's a great way of actually reducing your overall calorie count and hitting your calorie deficit. But I'm not overly convinced. I used to intermittent fast. Now, certainly if I'm training in the morning, there's no way I'd do it. And but I think for some people it does work. It's certainly an effective way of helping reach a calorie deficit. And just kind of I'll put this slide back on because in the 2 kind of peaks you've seen when Fahar started his first assault on his weight and lost weight quickly with no kind of nutrition plan, no exercise, but injections. What happened was he would have been burning fat, but he would have undoubtedly been burning muscle as well. This time around, I suspect he's doing something like this. He's putting muscle on and his body fat is decreasing and his overall net weight will gradually drift down. His body composition will be a lot healthier. And with that, his blood sugars, his blood pressure, his cholesterol will undoubtedly improve. Fahar, are you going to track your bloods as you do this?
Yes. So I had a baseline set of bloods, and the key thing is to track the data. And I think you'll talk about some of the work that we're doing to try and help people track some of their goals, and that a lot of this, the technology can really help under these circumstances. But tracking can be very, very helpful. And as you rightly say, you'll take 2 steps forward, you'll take 1 step back. I don't get too discouraged by the step back, because the overall plan and strategy is very, very clear. That small change, a long period of time, you recognize what your target and goals are. So if you relapse, that's fine, and you'll see that there will be fluctuations. But the key thing is to just
How often do you weigh yourself?
currently about twice a week.
Yeah, but I think if you weigh yourself daily, there will be fluctuations depending
Yep.
on how much fluid you've had. So, I think weekly or twice weekly is probably, because that gives you a clearer trend. And, when you're on holiday, accept that you're going to have that step back and enjoy life. So I've just this is a slide we had from last time when we did our first patient forum. We all need to be empowered by our own kind of taking charge of our own health. So knowing your numbers is something that certainly we're pushing very hard at One Heart Clinic. Your blood pressure, what your cholesterol should be. These are just broad-based for people who haven't had kind of established heart disease. And if you've unfortunately had heart attacks, then these numbers change. But in terms of what we're talking about today, we should be aiming for a BMI of 25 or less. If you were kind of interested, there were actually kind of criteria for body fat percentage, muscle percentage. And the other thing that we started doing now routinely in our patients is waist circumference, because that is a marker of your increased risk of metabolic syndrome, that increased visceral fat. And your HbA1c, which is a marker of diabetes, should be less than 42. So these are all tests that we now routinely offer our patients as part of their assessment, be it for a general checkup or for their symptoms. As I said to you kind of at the beginning, we're learning with you. I mean, all of this is new to us. And it was really, for me, the COVID pandemic, which made me get up and look at myself and think, right. Because what I kind of learned during the pandemic was there were 2 groups of people who got really sick. One was the group of people who just got a ton of virus coughed in their face. And the other was the group of people who were metabolically suboptimal in terms of their insulin resistance, their blood pressure. And this book was recommended by a friend. It's called Outlive by Peter Attia. It's my Bible in terms of how I conduct my own life. And it focuses on the 5 pillars, one being nutrition, one being exercise, one being sleep. I used to think you sleep when you're dead, sleep is for the weak. Utter nonsense. You need to sleep properly. You need sleep to clear your mind, to get a chance for your brain to clear out. You need sleep if you want to build muscle. The first half of your sleep, in deep sleep, is where you build your muscle. And then also kind of mental health and socializing, the idea that you need to socialize. We are social creatures. And it's actually got a whole lot of information about the science of, what causes dementia, heart attacks, cancer. But for me, the really useful bit is the second half, where it basically gives you a recipe on how to eat, how to exercise, breathing exercises for kind of mental health. And I think it's something that is written from a very personal perspective. I'd highly recommend it. It's clear to me that to make these changes, you need to overhaul your lifestyle. And as Rebecca said, it's really about getting the small steps in. So in my time, I've been called a master procrastinator, and I fully subscribe to that. If there is a reason not to do something, I will find it. But having read this book, I've got little tricks now that I've learned that stop me from doing that. So if I want to go to the gym first thing in the morning, how do I make sure that I don't get up when the alarm goes off and just look at it and go, well, no thanks? What I do is I have my gym kit literally next to me, my bag packed, my coffee mug kind of with the coffee already in. So what you're doing is basically reducing the friction. And I ensure that I get, the other way I do is I pay for a personal training session at that point, because if I don't turn up, I lose my money. And that for me as an Asian man is something that I just do not wish to subscribe to. So those are the 2 books that that I think everyone would benefit from in terms of if you're trying to overhaul your lifestyle. And just one more thing, we are hopefully in the next month or so going to release a new app called Launch, which basically will be your pocket coach and will allow you to keep your food diaries, which I think is an excellent time. You can actually snap everything you eat. And with this, it's got the Hallett AI algorithms built in. So if we've got kind of engines that if you snap a plate of food, it will almost it will use AI to estimate what the macronutrient count is, what the calorie count is. So you've actually got some data, and then you can obviously use that when you're meal planning. It allows you, it integrates with Apple Health, so it'll grab all your data. So I wear an Apple Watch for my sleep tracking, my steps, my exercise. And this is something I think, we've basically designed it for Har, myself, Shai, and our friends and family, and we hope that you'll be able to use it one day. So I think that's all I've got to say in terms of my contribution for this evening. Fahar, are there any questions from the floor that you think would be useful to share with the group? Anything that
Yeah.
you?
Yeah, there've been loads of common themes. There's a few things, and I think with Rosie and Rebecca here, we can address some of them. One of the issues is how do we increase our HDL cholesterol, for example? What are the changes you can do to help improve your HDL? That's one question. And aligned with that, there's a question is, what are the worst foods to avoid under these circumstances? I think some comments on the good stuff to be taking and the really bad things that are going to.
The question is, what are the worst foods to avoid for a high cholesterol?
For if you're worried about cardiovascular disease or if you've got heart disease, which are the types of foods which are the worst to avoid?
So Rosie, why didn't you take that?
Foods to avoid. So I would say sugary drinks are a big no-no. They're very calorie dense, so it's very easy to consume calories very quickly and then not filling. So it doesn't feel like you've eaten anything or had those calories. So it's very easy to go over with sugary drinks. So I'd say that's one of the biggest ones. Processed meats, so things like ham, stuff like that. That's the nutrition in that is not particularly beneficial for us.
Rosie, would you count freshly squeezed orange juice as a sugary drink?
It is a sugary drink. I think there is a limit that you can have around 150 mils a day as a max. And it would count towards your 5 a day, but I wouldn't go over.
So my view on that is a glass of orange juice and a glass of Coca-Cola have very similar calories and sugar content, but there's obviously nutrients. I'd rather eat 2 or 3 oranges where you've got all the fiber rather than the juice. So I think, and there is talk now of the government sugar tax being spread into fruit juice as well, which I'm supporting. Rebecca, what are your thoughts on that?
I think you're right. There was a big cult of the smoothie, certainly when I was going through university, and, great way to get all the nutrients in. But because you're stripping the fiber, the natural fiber, it's one of these other areas where you think you're doing the right thing, but in fact, actually, it might not be the most helpful. I mean, the key thing for me in terms of stressing the importance of diet, I think so many of us rely on takeaway food, fast food, highly processed, as you talked about, Rosie, highly processed meat, anything that's been highly processed white bread, white rice. So really thinking about stripping back your diet to a diet that you would have had maybe 100 years ago, how much of it can be natural, how much of it can be untampered with. And then also the importance, not just of the diet, but also the other factors that can help improve your HDL. So quitting smoking, for example, significantly will help improve your HDL. Doing more physical activity will also impact on your HDL. But equally, not beating yourself up if you can't meet that target, because some of it will be your genetics. So all of us are doing as much as we can to counteract our genetics, but there'll be a limit that we can achieve. And there'll be some occasions then when we need to rely on additional, pharmacotherapy drugs to help us get to those targets.
So I think your point about processed food is very well made and very well articulated. And Peter Attia, who I've already kind of wanged on about, has a nice way of saying, figuring out what's processed. And in essence, whatever food you're eating, imagine if you take it to your great grandparents. If they don't recognize it, it's probably processed. And the other thing that kind of he said that I hadn't really thought about, but it makes sense, is that if you want good quality, nutrient dense food in a supermarket, the best way of doing it is buy food from the perimeter of the supermarket, because you've got the veggies, the fish store, the fishmongers, the butchers, and all of that stuff. So it's the stuff centrally inside where you have the biscuits and crisps, etc., which obviously every now and then there is a place for it. And I think the other thing to say is, every now and then we're all human. But my kind of approach is saint during the week and a bit naughty during the weekend. Bahar, anything else? I think Rosie and Rebecca done a great job answering those questions.
Yeah, there's a great question that's just come through now about does your body deal with calories better before or after exercise? So when is the most optimal time to eat in terms of trying to maintain?
I'll tell you what I do. So I think if you want to have a productive exercise session, you do need to have calories, and those are the times I will have some carbohydrate. If I'm doing resistance training, I actually will, within an hour or so of finishing my resistance training, I will have a high protein meal, because what you've done during resistance training is kind of micro tears of your muscles that you're now need to kind of build again, and that's how muscles get bigger. They repair these micro tears. So my answer is, if you want a kind of an explosive, high performance exercise program, a meal with carbohydrates an hour and a half or before, or kind of something a bit sweeter just before. If you want to kind of, the one time I don't eat is if I'm doing kind of what my zone 2 kind of program, where I'm at 70% of my heart rate and it's kind of 30-40 minutes. I'm quite happy to do that without eating, because that's more, when you're doing zone 2, you're actually able to burn fat. You're not dependent on glucose. Whereas if you're doing kind of high intensity exercise, you've got to have carbohydrates to be able to fuel. Carbohydrates are your fuels, proteins are your building blocks. Right. So, and I mean, unless there's anything else that you think is worth discussing, we've kind of come up to the end of the hour. I think it's been helpful. Certainly, I've learned a lot, and the questions, it sounds like hopefully we've kind of passed on advice to the audience. So I'd like once again to thank all of you, the audience, for joining us. Please do provide us with any feedback if there's anything we could have done better. If there's anything you'd like to know next time, we hope to do more of these. And finally, thank you, Rebecca, Rosie, and Fahar for helping with this and for your excellent contributions. So unless anyone else has anything else to say, I'm going to close the meeting and wish you the very best for the rest of the evening. Bye for now. Thank you.
Thank you.